because the explanation of what we are saying could be due to the fact that PhDs, for example, after also everything. So if we do an annual summation, like numbers are aggregated. So you might be seeing that like it's an annual figure, the actual should be like led by 4 quarters. So that if that wasn't the research, you could have looked when you see that high variation. So if you capture in the 4 quarters, then the figure will become
Morning. My name is Julius. Again, I work with Mukobat. I want to say that the last slide has really raised a lot of concerns. But maybe we need to ask ourselves the processes that we go through to get this data and maybe the validation mechanisms in place. Maybe we need to question ourselves around that area. There's a big challenge with the quality of the data, and I think, like my colleague said, that data cleaning needs to be changed. But again, also, I don't want us to be so quick to just blame Ubos, or maybe only blame maybe the figures, because 37 million of households reporting to be having toilets means over 150 million Ugandans exist in that region alone. I mean, that's not justifiable, and that should have been detected at an earlier point before even that data is accepted in the system. So we need to check our flow in the M&E and try to put control. So maybe to the gentleman in front and maybe the partners. No data is not a one person's responsibility. It needs to start from the point of collection, the partner supporting the ICCM and the community health component up to the Ministry of Health. At the Ministry of Health and at the level of the nation, the Ministry of Health, it's all about detecting errors and providing feedback routinely and ensuring that there is follow-up for those errors to be corrected. So maybe which mechanisms are we putting in place to ensure validation and ensure that data cleaning is continuously done, not only prospectively but also retrospectively. Thank you very much.
Good morning, colleagues. I'm calling Utaruga Franklin from the Uganda Orthodox Medical Bureau. First, I would appreciate what you have done. But from my background, it's primary data and secondary data. And for you, you are now linking the primary data to analyze the primary data. You are going to secondary data, which has issues. You are going to show us the excess. But you might find even the deficit is high. Or even somebody speaking with a number from this region and put it in the language region like it was in the system. So this has an overhaul. As a matter of fact, more problems are within an estimates. In the part here, we reported to be exiting, getting exit. Even the way the population was clearly increasing. So we would like you to go back and analyze. And above all, these are blocks. Now, if a region like Bunyoro has 10 districts, maybe we would even be interested in knowing each district before you even come to the block. So, with due respect, I think let's not go for the easier secondary data. We get back on the desk and analyze the primary data, and then you can only compare afterwards. Thank you.
Thank you. Good morning, members. My name is Immaculate. I'm from UNFPA. When we speak about data, from the discussions that we've had since we started, we realize that our ability to roll out the community health strategy is going to run depend on quality data. My proposal is that we work very closely with the planning units in the districts, together with UBOS, so that UBOS can support these planning units to produce quality administrative data to start with. But also, we need to be mindful about the mandate issues of this country. We know where the mandate of data in this country falls, and we have to continue working with those units. UBOS has opportunity and I think it has the potential to produce small area estimation data, which helps to drill down specific indicators of our choice to the smallest administrative unit. I think as a country, or as partners, we might now have to take the lead to produce small area estimations on specific indicators that the community health strategy is going to be looking at. Thank you.
Thank you. Mine is about, my question is about the exposed infants data. Everyone of Africa is here this morning. Because I remember one of the things they do is to follow up these children that are exposed to make sure that they are either tested negative or they are positive, they are put in care. So, and then with the stigma associated, how do we say that this is a true reflection of the exposed infants in our communities?
Thank you. With the issues of quality already mentioned, I would want to know how the local governments or the districts where you already have electronic community health systems fare compared with those that are still analog. I don't know whether that classification is there. The second comment I wanted to make is before that is brought out, I think the national level links very closely with the biostats, who are our resource persons at the local government level. How I wish, as somebody said already, we could have this screen at that level, because some of our funders can get frustrated that we're doing little or nothing with the quality of information that we're using for decision making. And then lastly, I want to believe that as we bring this data, the information, the way we speak to it, or it speaks to us, should also be in line with what is happening at the community levels in the various regions. Because if you, for example, see the proportion of people who take their children to VHTs, children with fever to VHTs, if you see very high in the West Nile and in the North, and then very low in Kampala, I think it should not surprise you. Probably that goes with the level of poverty. A doctor like me, or a rich person in Kampala, is unlikely to take his or her child to a VHT. Those are the things that I think we should go to. Thank you.
Morning, colleagues. My name is Simon Bai. I work with Medic. Just to complement the question from the previous speaker, I think it would also be important to look at the before and after of digitization. What was the situation before in those districts that are being digitized, and are we seeing any value from digitization in terms of quality of data? And maybe just to quote the United Nations Statistical Commission that said, better data can be a matter of life and death. And as we go through the digitization with ECHIS, there are specific mechanisms that we are trying to put in place, of course with the Ministry of Health, to be able to identify the inconsistent and problematic data coming from the community health reports, and also being able to define what the remediation measures would look like. Because, with aggregate data, it's hard to walk backwards and determine where is the source of this data. But with electronic data, it's easy to go back and determine that this data actually came from this household and is related to this person. And if it comes to remediation, then that remediation of that poor quality data can be done at source. So my challenge to the ministry is to fast track the implementation of this server-side mechanism to be able to identify the inconsistent and problematic data as and when reported by the community health workers, and us being able to remediate that on time so that progressively, as we transition to digitization, we can build a very good foundation of quality data that can be able to inform the country on where interventions are needed, should we not be doing very well in specific indicators. Thank you.
Thank you. Good morning, everyone. By the name of Benson, I just want to give my simple comments on how we can improve. You know, we are all Ugandans, and these PhDs, in order for us to get quality data from them, I think the ministry should add a concept, a portion whereby whoever goes for services to PhD, they should enter that NIN number as a parent who has taken on somebody who has gone to get services. Why am I telling you this? I remember when we were doing household data collection, we moved with the LCs and then the VHDs, but others ended up entering and sitting, calling their sons or daughter just to come and start entering names of people alone, you know, without doing what they were supposed to do. Now, how we tracked them was, how did they get to know about now, like the breeding compound or like what the activities that they may lead to mosquito breeding drug. So the only thing that we can do is that, because when you go with your ID, you enter in, you know that, okay, this person here has received this service from the VHD. However, if it's not like that, they can sit and just count the numbers of the trees around that compound, and then they give it to you, and it will be a report. Thank you.
Good morning, everyone. My name is Michael Madenje. I work with the Professor Regional Referral Department of Community Health. If time allowed, I would wish that the principal monitoring and evaluation officer help us go through the data from the 27 districts that did give you data using the ECHIMS, right? And then my other concern about the indicators that you really projected, thank you. From day one, we've been really discussing issues related to PDM. And I think all our guest speakers were emphasizing issues related to what? PDM. From these indicators that you shared, please isolate for me clearly which one are we going to emphasize when it comes to that area. Thank you.
Okay. We need to be guided on how many questions we have. Because this is a very interesting conversation and we can spend a whole day, all week just discussing the indicators. But can we have the last thought from the lady?
Thank you so much for that presentation. To complement submissions by the previous speakers, mine is around the opportunity around how do we link the community aspects with the other platforms, specifically the health facilities? We are speaking to prevention. The workshop has really pronounced the term prevention. So how are we linking this? For example, you presented very good data around the management of the under 5, the sick children. So how is that relating to the OPD data that you are saying, for example? You've presented households that are using mosquito nets. How is it relating to the number of malaria cases, for example, that are actually going to the health facility. And I think one of the challenges we've had where that ownership has not been recognized at facilities is the linkage between the facility and the community aspect. So as a team, I think we have opportunities here so that we can integrate it further into the quarterly review discussions as we propose. Thank you.
Thank you so much. I will try to respond. But also I have colleagues from programs, and some of the questions are really directed to the commissioner, especially the classroom. But colleagues, it is interesting to just get discussion from the team. So I know that my presentation has got some level of interest which we wanted. So first and foremost, I need to clarify UCOS is an official and it is mandated to provide official statistics. No one is replacing UCOS when it comes to that mandate. However, I think in one of the quarterly performance review meetings, I think some of the directors here regional referral hospitals attended, were guided that internally, as we discussed, because it is not easy challenge to get data with statistics, especially when we want it, during the time we want it, and we tend to struggle. And I highlighted that most of the time we get estimates that are outdated, that are old. That is why you see that we can report coverage of about 180%, which is acceptable because of the estimates. We are not using the actual statistics, we are just using estimates. But we're guided that if we can improve our processes, if we can improve our databases, our systems of collecting data internally, as we are discussing as a ministry, and I know this is an internal meeting for community health. We can use our data for discussion and compare it to the August estimates. And that is what we are doing. So the spirit in which I propose that if we improve database at community level, it is something that we have that can be used close to population data, because it touches all households and the statistics are really comprehensive. And so the mandate still remains with us. Of course, we cannot publish any report, even our annual sector performance report, without using those statistics. So there is no way we are going to convince policymakers that the BHT database is richer or much better than those statistics. But internally, to improve, we can use it to discuss and improve our internal processes. The presentation, the actual intention was to just show where we are. We need to start from somewhere. Even programs that have better quality data started from somewhere. A lot of effort has been put in malaria data facilities, HIV data, TB data, and facilities. That all started like this. We start from somewhere. This is the picture as of today. Even when you want us to go back to the Ministry of Health and internally focus with biostats and program people, this is the picture of what we have in the system as of now. And really, you're the colleagues that implement at community level. And we expect that when we go back to going to support districts and the PhDs, the health assistants, and health center threes that really support the VHTs to report to make sure that we improve. We can see that most of the errors are data capture errors. Data capture errors. Probably colleague wanted to enter 1,000 and ended up entering 10,000. So the structure and structure is very clear. Data management structure, and we have mechanisms in place to make sure that we go through that structure and improve quality of the reports. But we need to put in effort. We need to put in effort, and also the relationship between quality and use. If there is no demand from colleagues, bosses at the district, sub-county colleagues, the VHTs cannot improve, because that is what they report. So if no one is using the data, we don't know the standards and we want to improve. So really, this conversation here is to make us get interested in looking at the statistics that we report, that we get from the system, and see whether it is good quality, it is something that we can rely on, identify areas where we can improve. Now, this is the primary data that we're looking at. This is data that is reported and entered by VHTs. It is not secondary data, as colleagues put it. It would be ideal if we all get support to just get interested and look at the VHT register. Because it is from the register that this report is generated. So, obviously, because it is done manually, and some of our PhDs have, of course, have capacity issues. We all have capacity issues, and we need to be supported. So, if we support them to just minimize on the errors at entry, at the register, entry in the report, then we can gradually improve. Quarterly versus annual, yes, I haven't highlighted on this, but really the numbers that you can see. Even if it is cumulative annual, 36 million, you divide it by 4, you're going to get 9 million. Is that realistic? Households. And the sub-region, that is not realistic. Obviously, there are issues at entry, there are issues at aggregation, but if we don't identify them, we have a problem. So we are going to start from there and see if the gaps at entry or the gaps at system level, and we do data validation and cleaning. So yes, districts are supposed to support and do the data cleaning exercise and validation exercises to make sure that we improve quality. This depends on support from partners and also internally from government. And I think we can, if we prioritize this, as we prioritize other reports, if we prioritize this, I think we can improve quality and start looking at the data and supporting the processes. I talked about the Thursday meeting where we convened and colleagues have requested a comparison of districts where we've digitized. Those cannot digitize yet, how the data looks like. We usually disseminate this report weekly, so I will advise colleagues, in the interest of time, I cannot present that. I'll advise colleagues to join that weekly call. We are going to share links. It is an online meeting that happens every Thursday at 9. We usually look at and focus on a few parameters, and we compare districts that are digitized and those that are not digitized, and we learn from each other. Please endeavor to join, and we look at that together and see the lessons. community, I think that Commissioner and the team will highlight that. But of course, we will need more time to just discuss indicators, discuss linkages, discuss contribution, the work of initiatives to the overall national picture. But as of now, I think it is not a discussion that we can initiate now, but hopefully we can have those engagements going on and try to understand how and what is the contribution of initiatives to overall sector performance and performance of health facilities. So I don't know if I have left out anything. Did I leave out anything? Yes. We'll have two, one from Dr. Kanya, as we go through this.
Thank you very much, Chair. Once again, I'm Dr. Kanya. Chair, now, from yesterday and all the days that things have seen, we need to be very clear, especially from the speech from the Commander Secretary. What do we want to do? What results do we want to get? I think that should be very clear. The other thing I want to ask you very clear, Commissioner and your team, is to know the mandates of every organ at every level. To know the mandate of the local government structure, to know the mandate of the Ministry of Defense. I've been struggling with the parliament, but actually now doing very well of understanding those mandates. From what all the discussion I've seen and presentation, I'm seeing the local government not coming out clear. That's what I've been asking my parents here. Because when we have that decision, the local government, the DHO are doing very well, because they are the implementers. For you to make any impact on local government, when the DHO does not take leadership, you are in trouble. You are in trouble. Because it is the DHO who is going to implement. Now, all of these data issues, you are troubling with in Kampala. Must be solved at that district level. Actually, for me, I've been trying to take the data deep dive when I've started to understand and clear those things. Now, the one is that troubling with data in Kampala, you are in trouble. I know you never get an agreement. Even if you put in computer electronic, that's something I've never shared on our platform. These computer electronic do not get cleaned. As long as data from the source is not cleaned in there. For the time myself with. But I think I'll get time to discuss with my brother, the commissioner, on deep dive on how we improve it. Thank you.
Thank you, Dr. Kanya.
Thank you so much, Doctor. I would like to share my reflections that I agree. We need to make sure that we have clean administration data. But also I'd like to propose that even if it might need for us to make a small agenda, guideline, you see that we don't have Minister of Finance, planning and yet they are the ones who are supervising UBOS that prepares and is in charge of the national statistics. So I would like to propose that we have a reflection on how we bring Minister of Finance on board with specific areas of their contribution, just like we have done for the other sectors. Thank you.
Thank you so much. I think that has been noted, but just to give you an update, we have national working committees, especially looking at new programming under the human capital development, for example. We have a representation, we have a statistics committee and data management committee where we have our UBOS, Ministry of Finance, National Planning Authority on board, but these are just preliminary stages. We hope with continuous engagement will improve, and there is an opportunity for us to engage and improve, especially in the area of official statistics and estimates. Hopefully we will get there someday. When it comes to forgotten, colleague raised a question on which of these PPM and indicators, if at a district level, if you look clearly, M&E framework of PDN, you'll see that under the health subdomain, the indicators that are close to what I've presented. The only issue is that we haven't integrated yet. We try to start integrating PDN in Portugal, but also that pilot hasn't started yet. We are still struggling with releasing resources and all that. But we have integrated indicators that we are tracking at PhD level already within PDN logical framework. But also, I highlighted that some of the indicators, especially the indicators where the PS pointed us to, we haven't functionalized those processes yet. So we haven't started tracking them. So we can have better reports on them. But we'll start tracking as soon as they are operationalized. Colleagues, thank you so much. We can pick those questions and we can try to respond to the commission through thank you.
Thank you very much, Mr. Kwamwati. Commissioner Dr. Pedro, you wanted to make a submission, maybe you can come to podium. Meanwhile, I'll do a uniform hospital treated.
Okay, let me start by welcoming some of you are still in the Yemen spirit, but I hope all went well. And this should be a very brief session today to allow us also get away from this space a little early. I just want to repeat what I would have said last week, but just let you know that this particular presentation from Mr. Martin was really to imprint all of us to begin thinking about what the peer said. That in all what we do, she wants to see high impact interventions. But if you're going to do high impact interventions, we will need the data. But of course, as you also know, at the parish level, there is the parish, they call it parish management information system. That is supposed to capture data at that level. But we took our data capture right to household. And I think this team must have a mechanism of how they can channel that data through the parish management information system before even it reaches the district. And that's something which we started thinking through, that even now as we think of taking services to household, how shall our data get married to the one parish development model before it gets to the district? And ideally, the custodian of all this we are trying to agitate for is the district. That's like Dr. Kamil said. We many times tend to bypass the district. But as you remember, the whole of our discussion today was based on this conceptual framework of the national health system. And if you read carefully our national community strategy, it's system-based strategy. And takes us through the 6 building block, but plus added the 7th. And the 7th is the community engagement, which is not yet inside the 60 building block of that WHO. Like I said at the beginning, the red ones are the original ones. The green ones have been actually added by WHO. And to us, in Minister, when we picked it as it was and added it to our, conceptual framework. Because, as you know, and we have said, we now will have two service delivery platforms. The facility-based service delivery platform has been with us for ages, and even up to now. It has issues. And we should know that in the facility-based service delivery platform is even more enormous than what we see in the community-based service delivery platform. But we also want to be there. We want to be somewhere where now we can use community-level indicators for planning, for programming, for budgeting. And I said it earlier. In our joint review mission, all our indicators are facility-based. And yet, all what we report are from the community. But because the indicators are all captured, all the data were captured at facilities, we at the community space, in the community space, we have nothing almost to report. And so, as we continue to get into the community space, services of the community, we need to start thinking what kind of data should we use. Now, this to me should be an eye-opener. That if we are not careful, planning with our community is going to defeat us. If this is the kind of data we are going to base on. Now, for this particular retreat, and as you know, retreat is really interrogating ourselves. And that's why we say, also as Minister of Health, we are coming here as mutual partner. Almost everyone of us is coming at that equal opportunity that I have something to put in this space. And so our desire for this particular retreat was that we will look at the two building blocks of community-based trained health workers and community-based health promotion and health care pillars. Reasons, we already have the essential healthcare package coming in place. But who are going to deliver that? Okay? Who is going to deliver that? And that's why we say this particular time, we want to address ourselves to that, and as partners, we map ourselves. And that's why we said almost every player in the community space to be present here and interrogate ourselves and say, where are we and where are we going in this kind of space we are undertaking? The community space is like the bottom of the sea. In that sea, there are crocodiles, there are fish, there are reptiles, there are dead bodies of people who have survived a long time ago and those who have just passed away yesterday, including sunken ships and wreckages of those ships you have heard about now. It's us to tease out what is it that we want to fish out from that sea. If you take a hook, you will catch one fish at a time. If you take a net, you will swim as many, but depending on the size, you will swim to the lizards, crocodiles, and amphibians. Okay? So we thought we will start small, but we have discovered, as we are going through in this retreat, that if we are taking services and we don't treat ourselves with the data that we use for monitoring ourselves and we take services using this essential healthcare package, and with the kind of workforce we have, the data will embarrass us. But for us, let's not be embarrassed because we are just starting. The U-boats who have been there in the space, you can see also how they are like amateurs. Okay? But when we apply ourselves, even when we put ourselves on the weight scale, kilo by kilo, kilo for, you put the computer space data here, how we want to actually, digitize our data. With the facilities, who also are struggling on the other side to digitize their data. The people in the FRD will tell you that the community health space will be better than the facility. Let alone this kind of hiccup you are seeing. But the bottom line is, if for us we want to achieve results, let's have the district own these interventions that take people are doing this. You said for me the next slide. Colleagues, it was intentional that we decided to bring this particular slide here. And again, I will continue to repeat. If we are saying community health service delivery platform and the facility-based service delivery platform are two sides of the same coin, there is no way we are going to leave the local government health system hanging as we have been doing. We got to actually devolve whatever was being done at the center to the local government health system. These are not my slides. These slides were presented to us at the 2020 mission. It's a government position that now we will use the local government system for health to deepen community services until we reach the household. Because that's their system. And that's why we are working the regional referral hospital here. And we all know the reason why the community health department for regional referral hospital was established. And this is now going to be one of their core activities. To make sure that using this hammer scope they were preaching yesterday and the other day, they make it a point to strengthen the district in their catchment area. For the district to be able to use the same model to strengthen the facilities which is within their catchment area. So that through that, even the data we are talking about doesn't become an issue of the Ministry of Health. It's actually the issue of the local government. So that we as Ministry of Health, at the same time, we cannot say, this is our new boss. Do you own this data we are going to use for planning and for programming, including budgeting? That should be the way to go. But I like the discussion. It's very healthy because we are thinking that in the next retreat, we should come with something different. Ideally, we had thought, and that was what we also agreed in our last retreat in Canada, that we will not be waiting for the year to end, then we begin to assess ourselves and then interrogate ourselves for what we can do so that we strengthen all the 7 building blocks of the community system building structures. We will do it quarterly. Courtesy of USAID, we are asked to request support from one partner, and that partner also given us one M&E who will make sure that every quarter we are meeting and looking at the progress and what we are doing vis-a-vis the data we are collecting as a community. Unfortunately, UHS passed away. But we don't know where we are buried. We just had that today passed away. Now that's the dilemma we are in. But we are very, very sure that another child will be born that can pick it up for us, and we see how to deal with it. Otherwise, we want to thank Mr. Martin. Mr. Martin, I like the way you presented the data grow as they are. If you are trying to cook, people of our children will say you are receiving us. But people of you are still not happy with you. But that's a discussion for another day. Thank you very much. People of you, the master of program is still here. Thank you. Classes.
Thank you so much, Commissioner, and thank you so much, Martin. We are going to our next second last agenda item. We could not leave because we had all regional hospitals here. Specifically, to make sure that this time round, coordination and deepening committee role was a priority. So I'm going to invite, we were supposed to have all of them give us what they worked on yesterday, but we are going to have one regional referral hospital take us through their coordination plan on how we are going to coordinate partners, coordinate services and work with districts, and then we guide them. And then the rest of the regional referral hospitals, we use that one plan that we've said we've guided on. So the head of the community health department, Rural Regional Referral Hospital, are you ready? Please come and take up the podium. I know yesterday, as he comes, I wish to make mention that we in this retreat, we had a total of 49 partners. And yesterday, Mbara was complaining that he had only one partner. When I looked at the mapping to Mbara, you have 11 partners. The regional power hospital. So after there, we are supposed to share the partner list with all regional power hospitals. If you're ready, please come.
Thank you. Good morning. For purpose of saving time, we work together. This is a young region for the entire Western region. So it's very good.
All right. Thank you, Chair. Good morning, ladies and gentlemen. Good morning. As my colleague has just said, we work as the Western region, which has two regional powers. That's Unibet and the Rule. So whatever we're presenting here will be on behalf of West Nile. This one, as I get through, Dr. Patrick Mojaku, head of Community Health Department, Regional Referral Hospital. My colleague who has just left is Rodrigo Christopher, head of Community Health Department, Regional Referral Hospital. This that we are presenting, this is a living document which we'll keep working on, and we'll get a better version possibly at the end of this engagement. This is West Nile. We have 13 districts with one city. That's the profile, the demographic profile. Population of 4.2. And that application you can look at. We're hosting refugees. Of the about 4.2, 700,000 are refugees spread across the region, the different districts. Adjumani, that takes the bulk with about 212. Koboko, Mariokolo, Ogongi, Terego, and Yumbe. So all these aggregates to 700,000 refugees. The partners that we have in the region, many among these that we have listed. Here we have both implementing and development partners. It's a mix, but we'll bear to forgive us that we have not been able to put them in the rightful order. But nevertheless, these are the partners that we work with in West Nile.
And it's not a comprehensive list, as I say. Some might be here, some are missing. Not that we have forgotten about you, but we'll keep working on this and have you reflected. So we have development partners like UNICEF, World Health Organization, UNHCR, UNFPA that do a lot of work in West Nile in the key different areas that we have highlighted, including CDC. Those are the key development partners that we have. Then the implementing partners, as listed, with key being there is ITI, that looks at HIV, TB, and global health security across all the districts in West Nile. Accord has livelihood activities in the refugee settlements. IRSC and MTI, these are the implementing partners, and UNHCR that takes lead in health services in the refugee hosting districts that are listed there. Then Uganda Red Cross Society, that we traditionally knew for disaster and emergency response, now has other activities that also they implement the community watch, community-based surveillance, and hygiene promotion in the districts of West Nile, specifically Mariokolo, Paloringa refugee settlement that is in Moyo. Also we continue with others, Plan International, that takes the reproductive health activities in refugee settlements. MTI, as I alluded to, that's implementing partner under UNHCR. Strong Minds, also in West Nile, as mental health. TASO is one of our key partners that handles ICCM in all 11 districts of West Nile. OPM, we cannot go without mentioning the issues of security is under the Rice West Nile, Productive Health Uganda, Maristops, EPO. These are some of the partners that we work with. We will not exhaust the whole list. We have PMI, UCMP, UPMP. Some of these partners like UCMP, UPMP, they work in the districts, but realize for them their interest is in facilities. Those PMP facilities where they support some of these TB, HIV care activities. On analysis of regional performance, say this is work in progress. Having had what was just shared on issue of performance, indicators and rest, we are not committed to this, but we believe at the end of this we will still go to the round table and have these indicators reflected as expected, so that we know at the end of the day what our performance will be evaluated against. As far as regional support to the districts, the hub and spoke, our regional referral hospital has 8 districts. The need assessment, that is the Apache, Nembi, Zongo, Maroko, Terebo, and Maracha, Arua, and Arua City. Whereas Yumbe Regional Referral Hospital has 5 districts, Yumbe, Koboko, Jumani. As a region, we have agreed that we shall have a minimum standard activity package that shall be developed and shared, that shall be implemented by all local governments and partners, the CISOs in the region. Even when your core manages HIV, they are not going to implement this there within the community. So we want you to carry on other areas to also implement. When you wash, nutrition all should be embedded in, and you move along in an integrated manner. Target setting, we only look at some of the priority areas that we think we should be able to look at. We look at areas like sanitation and hygiene. We will be interested in latrine coverage and the use, not only having the latrines but also the utilization, safe water coverage, and washing facilities. And also, we'll be interested in nutritional interventions. I think we all remember what the PS talked about, issues of nutrition in the community. So we want to look at the household mark, food demonstration guidance, vitamin A supplementation and deworming as part of nutritional interventions. Malaria activities, we have key players, TMI, that is one of the key players. We shall have household action against malaria, so we expect to have smartphones, ICCM, integrated community dialogue meetings. This will be one of our key activities to undertake. Questions from the communities that will get what they need, and so we plan according to what they think we should offer to them. Then school health activities. Here we want to look at how we engage these young people in schools to promote issues of malaria prevention, guidance of repellent plants, which you can use this young workforce to improve their homes by planting these kind of plants around their homes. Talking compounds, this we all know what it entails when it comes to school programs. Then also engage them in drama and dance and music, so that some of these messages they can share them to their colleagues. Then Health Week, where we intend to have advocacy through leaders for integrated community health interventions. Then TB HIV activities. We have hotspots within the region where we want to have targeted HIV testing services, elimination of mother to child transmission, integration with all other service provision opportunities, CAS TB plus, especially hotspots. Also, we want to prioritize mental health, having that big population of refugees in the region. We know what it means to be a refugee as a region, and it has issues of mental health that we are grappling with. So we want to create awareness, messages and dissemination, engagement of leaders, both political, civic, religious and cultural, and then enforcement of laws. We all had here the other day when we had a mentioning about substance abuse, and we are guided that we have laws that we only now needed to enforce against some of these substance abuses that we know also has a hand in the mental health of the community. Then immunization, outreaches, those are things that we want to undertake. For issues of coordination and planning mechanism, the regional referral hospitals will take lead through the community health department. But we realize we are not going to do this alone. We need the districts, which I would say are autonomous. And so we have the key resource persons in the district, the COWs, RDCs, LC5, and GSOs. These are the people that we are going to work with. We realize that the COW is the accounting officer. the district. So the DHO is answerable to the cow. But main intervention that we have, go to the district, we interface with the DHO, the cow will get to know that such a thing occurred in his district at a later time. So we therefore think, if we have an engagement at the district, we need to bring on the cow and also the political part that the LCFI and the representative of the president at the district, that's RDC. These are our key players spearhead the regional intervention. While at the district, of course, the office of the DHO will take the lead with their 8 DHOs, both environmental and mechanical health. So I wanted to be one. District health educator, the biostatisticians. These are our key players who will guide us with issue of data. When the previous presenter last data here, raised eyebrows. So these will be using the biostatisticians at the districts to help us with issue of data. And then the partners and the civil society organizations that we listed. So that's how we, as West Nile, think we shall be able to coordinate issues of community health in the region. That is where
thank you very much, Anwar Regional Referral Hospital. Now I'm going with, by 11:30, we must be through the discussion which are going to follow. Because by midday, for us who work in UN agencies, this Friday we are not even supposed to go to times. So we shall have finished whatever we are doing here, and we shall of course. That's why I wasn't not putting one in time to do. Yeah, so now we are entering the discussion mode. I would request regional referral hospitals to submit if there's anything that Anwar has missed and you want it incorporated, please, you should have 5 minutes. The discussion must be only 5 minutes, right? Yes. Yes. Can someone move? We're not sharing this.
This presentation for West Nile.
Hey, for West Nile.
West Nile, as you know, the country has been divided in two.
Can you tell me that later first? Yes, that's the rule.
This country has been divided in two.
Yes.
USA supported regions.
Okay.
And cities supported regions.
Yes.
Of which one of them is USA supported.
USA is supported.
So it would be fair for us to have both sides of the story.
Okay.
USAID and also the cities.
The cities.
So that's why I suggested let's have also one selection from the USA supported regions to present. Then now have.
So this was citizenship.
Yes.
Yes, Commissioner, how do you like? Can we proceed with the... If I have time up to half past, okay, very good. Then we manage that. 18 past 11, so that means that the USAID region should use 4 minutes, right? Very good. Okay, can you please write the submission? You are not those present? Yes, so we give you how many minutes? Very good. Very good. Very good. You are attentive. 3 minutes, please. 3 minutes. Because
I'll summarize. Yeah. You know, we are not reinventing the wheel. What we are doing exactly is to functionalize the structure that are already existing. So we are looking at the regional referral hospital as being a structure which is going to lead us there. And at the regional referral hospital, for us to have what we call the GPG, or USAID supported regions have what we call the G2G mechanism, through which we have the hub and spoke. And I talked about the hub and spoke the other day.